Good afternoon and welcome back from lunch. Have you had your cup of coffee or tea yet? So I hope you will be very stimulated in this session because we're talking about the ethics of Alzheimer's disease testing. I think the revolution in genetics lately has presented us a very clear case for the need to reconsider ethical issues with regard to genetic testing. Issues such as what are the implications of the social, psychological, and behavioral consequences of such testing, and to what extent does this testing affect patients, families, and the healthcare system? And more importantly, is this something desirable? So today we have two panelists who will be addressing all these issues from their perspectives. So first of all, may I invite Dr. Karen Muskie, who is a research scholar of the Hastings Center, to present her views first. Thank you, Karen.
I failed the first time to thank CUHK and the committee for inviting me to be here, and you all have been wonderful hosts. It's been really great to meet everyone. I'm going to start with two themes, and I'm hoping that it will move clearly into the second presentation. And if not, then our next speaker can correct me or challenge me on some of the questions and issues that I raise. I want to talk about the notion of technology assessment and the technological imperative in terms of diagnostics and for Alzheimer's in particular. And then I'm going to move from that theme to talk more about these larger ethical issues when we do diagnostic testing. And I'm going to start with a very short description of a controversy in the US right now. The only so-called close to national healthcare system we have in the US is for Medicare and Medicaid. Medicare is a US-funded program for insurance coverage for patients 65 years and older, and younger patients who have specific conditions that fall under the Medicare Act. And recently, a technology developer known as the Lilly Corporation, some of you may know that organization, asked for Medicare to pay for insurance coverage, to pay for a diagnostic that's called amyloid or beta amyloid PET imaging, which will show the extent of amyloid plaque in living brain. And the argument is that this is a diagnostic test of a biomarker, amyloid plaque. And the amyloid thesis, those of you who are involved in Alzheimer's will know this is the reigning hypothesis of the causative agent for Alzheimer's disease. Other issues are at stake, but amyloid plaque is one of the reigning theses. And the Medicare program denied the request to cover this. So that means that patients in the United States right now cannot get insurance coverage. They cannot get the testing paid for if their doctor says they should have this test. And there's a lawsuit challenging that decision. The reason that the Medicaid organization made the decision, there are a number of reasons, but one of the key issues was their claim that the evidence base for this diagnostic tool is not sufficient to show that by getting this amyloid PET imaging, that the result will be improved patient outcomes. That is, it's an effectiveness claim, but there's no effective improvement in clinical management because there are no treatments yet, effective treatments to change the outcome of Alzheimer's. There are certain drugs that those of you know about who are in the field that can moderate the symptoms of Alzheimer's, and that might even slow progression, but that's even questionable. So the issue I want to raise is the introductory theme is this notion of evidence-based diagnostics. The amyloid plaque diagnostic tool, PET imaging, is a brain imaging tool. But the flip side of a diagnostic for Alzheimer's might be a genetic test. And so those of you, again, in the genetics world know that there are a number of genetic markers now that are at very high, there's very high confidence on the part of some researchers that APOE4 variant, and there's another genetic variant and a few others that are being tested that may be clear indications of an individual being at risk for Alzheimer's if they have those gene variants. What I want to raise to think about is the notion that came up in earlier sessions about the notion of at-risk status and what that means in terms of testing at the diagnostic level, and whether or not a diagnostic tool like genetic testing or PET scans or there are other kinds of imaging that one can do of the brain. There's also spinal fluid tests that can be done, other kinds of imaging modalities that provide information about a biomarker that may have an indication that the patient is at risk for the condition, but is not actually clearly yet has a strong evidence base that those biomarkers are actually causative agents. So this is sort of the debate going on in the evidence-based world about diagnostic testing, and particularly about whether or not insurers should pay for this testing. It may be that the clinician thinks that the test, combined with other diagnostic criteria, again, in terms of looking at cognitive impairment, there are other kinds of tests that one does to measure a person's cognitive impairment or decline over time. So combined with all of those tests, a clinician may feel very confident in his or her diagnosis that the patient has mild cognitive impairment, Alzheimer's dementia, Parkinson's, or other forms of dementia. Insurers, however, in the United States at least, are balking at these diagnostic, particularly these physical diagnostic tests and the genetic diagnostic tests, because they don't see, in their view, clear evidence that the diagnostic test in and of itself shows that the patient actually has the condition or will get the condition, and therefore are reluctant to pay for it. And that raises a lot of the interesting issues that came up yesterday in the discussions about health services and costs, and how we control costs and how we evaluate technologies. Because many people in the United States have argued that a lot of the cost of medicine in the US is based on this technological imperative. If we have the technology to do it, we should do it, and we should pay for whatever it costs to do. So I want to lay that out as sort of an interesting frame to think about in terms of a diagnostic tool for disease that's very devastating, but for which there's no treatment, A, and which there's a discussion now about moving the definition of the disease at an earlier stage called a biomarker stage, and the debate over what it means to have a biomarker and whether that in fact means you will actually get the disease, okay? So I'm framing it by that. The second point I want to raise then is the issue about what we do when we have these tests. Let's assume for purposes of discussion that Medicare in the United States agrees to pay for it. So now you have thousands of people aged 65 years and older who now have access to a diagnostic tool, which actually, by the way, right now costs between $3,000 and $5,000 per test. I'm talking about the PET scan with the radio tracer. So that's a very costly diagnostic intervention. But let's say that the organization agreed to pay for it. Now the question I think we get to is very much like the discussion we've had earlier today and yesterday. Who should get the test? Should everybody over the age of 65 who has a memory problem, which is very standard in aging? Memory decline is a function of aging. I, for one, can attest to that now, as I have reached the threshold, above the threshold of AARP, one of the leading organizations in the United States that supports older Americans. It used to be that you were a member of AARP when you were 55 and older, and now they've lowered it to 50. So I'm officially now, I'm much older than both of those. Memory decline is a part of normal aging, as is physical decline. And someone mentioned yesterday people get frail when they get older. Well, they also have memory issues. But there's a difference between memory decline as a part of the normal function of aging and cognitive impairment as a clinical condition, which has other kinds of cascade effects that may happen, and a diagnosis of a disease like Parkinson's disease or Alzheimer's disease, which we all know has other comorbidities with it and has other kinds of physical ailments that are associated with those diseases that put us on a trajectory of gradual decline and then leads to death. So the question then, I think, is, in my view, and many people may disagree with me, but in my view, it's very similar to some of the genetic testing. Who gets tested? Should this be a test, whether it's a genetic test for APOE or any other gene variant, or any kind of brain imaging test that shows amyloid plaque, or if there's some other hypothesis of brain deterioration that becomes a prominent paradigm theory, should everybody at a certain point in their lives get these tests? Now, in the genetic context, the issue came up today and it came up yesterday, What if we can do a whole genome sequence of a newborn and find that all newborns who are sequenced, a certain percentage of them have the gene variant or variants that suggest a person is at risk for Alzheimer's? Do we do that at the newborn stage? And if we do that, what do we do with that information? And there's been some discussion now in the literature about whether or not children at the newborn stage, or even at the young pre-adolescent stage, should be getting tested for adult onset diseases, particularly if at the time of the testing, let's say today, 2015, the information is at-risk information. It is not clearly causative information. So another question then would be, well, let's go away from the adolescent or the newborn stage and let's talk about the adult stage. What about screening for Alzheimer's disease? Screening either through genetic testing or through brain imaging. What would that mean in a healthcare system? Whether it's a healthcare system in a national health service system, whether it's a healthcare systems, one might argue in the United States, with different payers and different levels of access, should we have universal screening? And from a public health perspective, sometimes we argue that we should have universal screening for certain kinds of conditions. There's a huge debate in the United States right now about whether there should be universal screening for prostate cancer, the PSA testing, and whether or not everyone should have that, every male should have that at a certain age. There's a debate about mammography screening. At what point do women need to have a mammography every year, or every 2 years, or every 3 years? And should, in our system, we have varying payment plans, should varying insurers pay for that? So who should be tested? Another question is, do we want the tests themselves to add to improving patient outcomes? And again, there's an analogy to the genetic context. What if there is no treatment available? There absolutely are no drugs available at this time or other interventions that can literally change the natural progression of the disease of Alzheimer's. Clearly, we have some behavioral interventions. We do have some drug interventions that can mediate depression and other kinds of behavioral problems that occur with people who have Alzheimer's, but there is nothing available right now to actually stop the progression of the disease. Similarly, in some of the genetic contexts, does that mean then that people should not get tested? And what about having access to that information? And that comes back into whether or not there's something actionable that can be done. Is there a clinical utility in actually having the information? A third question then is, which tests should be used first? So in the Alzheimer's context, it's actually quite interesting because it might be that there are multiple kinds of tests that can be used in conjunction with each other, which actually increase the reliability of the clinician's diagnostic outcome. So maybe combined with genetic testing, brain imaging, other kinds of cognitive behavioral testing, maybe there might be in whole, all of these tests together might actually make us feel confident of a diagnosis. Again, though, that leads us to question, if that's true, then should everyone at a certain stage in life or with certain kinds of cognitive impairments get all of those tests? And again, in a system like the United States, which is not a single payer system, who's going to pay for that? And should Medicare program pay for that? A fifth question then is, how do we evaluate the costs of incorporating new or established tests into current health services? And this is a larger issue in the US about the use of new technologies. Just because they're available, do we always use them? And for a lot of really good reasons, patients and their clinicians often are really pressuring to have access to these tests. Now, I thought it was interesting, one of the slides this morning about the prenatal testing and the companies in Hong Kong. Several points were made about, this is a very lucrative industry. And organizations like Lilly Corporation and, the major pharmaceutical companies and the biotech companies that are creating imaging technologies put a lot of money into the research. And they get to a point where they go to get approval to market their products. And, for good reasons, they feel that they have sufficient evidence now to introduce this into the clinical setting. Patients hear about this. We all know now that with patient organizations and the internet, patients hear about these modalities. Their clinicians are on professional organizations. They go to conferences. They hear about these tests. There's great enthusiasm that the next test is going to be the test that tells us what we need to know, that's going to lead to, in a diagnostic category, the enthusiasm is the diagnostic modality is going to help in the research enterprise to lead to that magic bullet of the drug or the other intervention that's going to help either ameliorate the disease or cure it. And so there's great enthusiasm then for patients, understandably, to want to get a test. Again, how does this impact the healthcare system? I don't remember the data yesterday from Victor and others, but the numbers are striking in terms of the number of people who are going to be aging, the number of people who are going to be at certain ages where cognitive decline may mean something more than just aging. And the cost figures are significant in terms of testing, let alone with interventions for cure. Another question has to do with who makes the decision for testing? Now, in an aging adult with some memory impairment, maybe some mild cognitive decline, in a research and clinical context, we would ask whether or not that person has the capacity to make a decision about consent to enter a research study or to make a decision about life-sustaining treatments if they've been diagnosed with a disease, or even just about regular clinical care for whatever they're being treated for. At a different level, if you have an older person with serious memory decline and maybe on the path towards Alzheimer's or another dementia, the question then is, who makes this decision about testing? And I'm not raising this because I think this is something new, but I'm raising it in the context of a new technology. If the technology in and of itself is not yet something that gives us a clear diagnosis and is very new and is being pushed under what some would call the technological imperative, we're going to rely on surrogates to make decisions about whether or not to undergo genetic testing for Alzheimer's or to undergo brain testing. And I'm not saying that's in and of itself a problem, but it does raise some questions if we're at that moment where payers are not willing to pay for the test because they don't think the evidence base yet is sufficient to introduce it into the clinical setting, and yet we still need people to be to undergo these tests sometimes in the research context. So we're raising some interesting questions about the issue of consent, about the issue of surrogate consent, and what that means for various diseases of, that result in cognitive incapacities. On another level, there's an issue about at what age do we test? Now, most of the literature that I've looked at on the issue about PET imaging and brain scans doesn't really talk about age of onset or age of adulthood. But I think it's an important question because even in the genetics context, if we take the genetics context and talk about testing children, at what point in an adult context do we think that genetic testing is important for a cognitive disease? And again, if the age of being a senior keeps moving lower down the age spectrum, and if science actually begins to show us that biomarkers begin to appear at earlier ages, which is in fact what's being discovered with regard to amyloid plaque and other kinds of brain development, earlier on in adulthood actually, may if there really is a good biomarker for a preclinical disease, it may actually be earlier in adulthood than many of us would think as being a senior or being old. So again, that raises some interesting questions about decisions about public health screening, about individual choices about testing, about families and the information that families are going to get about a loved one who may be tested at a much earlier age than one would think would be the case. You know, I think at least in my brain, I have a stereotypical view of a grandmother or a grandfather getting tested for a cognitive condition, and if a biomarker preclinical stage of a disease like Alzheimer's can actually be identified, and we have good confidence that this is a biomarker that's going to show some progression of disease, we may be talking now about a really early age at which we're thinking about individual decisions to be tested or maybe public health screening. And that raises some interesting questions then about the role of public health screening and the role of public health prevention and treatment. Finally, I want to raise an issue about the role of overdiagnosis and how insurers, payers, get connected into this notion of overdiagnosis and what some people actually think is an increasing issue in health services and healthcare systems. In the UK, and some of you in this audience may know more about this than I do, but there was an initiative that I think is actually being scaled back. In the UK, there has been a push for physicians to diagnose people with Alzheimer's and to report to do better diagnostic testing. And numbers were kept as to how many patients were actually being diagnosed with Alzheimer's. And there's been some pushback because many physicians in the NIH have felt that they're being pressured to overdiagnose so that their institution can get paid for the testing. A couple of recent articles that came out that raised this issue about not only pressuring physicians to diagnose Alzheimer's, but what does it mean for the patient in terms of potential harms to be diagnosed for something that one maybe doesn't have or it doesn't have at the stage of that diagnosis. And so that came up yesterday and today as well, the issue of do no harm. Do we actually harm patients and their families if we use technologies in a way that might lead to a diagnosis of something that may not actually be at a point where we need to do something about it or that we can do something about it? And is there any harm in that we should think about? Not saying we shouldn't do it, but should we consider what potential harms may result in that? Thanks.
Thank you, Karen, for raising a number of questions for us to think about. May I now invite our second speaker, Professor Linda Lam. Professor Lam is the chairman of the Department of Psychiatry of the Chinese University of Hong Kong. Professor Lam, please.
Yeah, thank you, Chairman. Thank you very much for giving me this chance to share with you some of our concerns as clinicians. So I think I would take this opportunity to reconsolidate some of the points proposed by Karen and from a perspective of a clinician working in this community. So the first question is, if there is a blood test that may predict the onset of clinical Alzheimer's disease, cognitive impairment in 2 to 3 years with 90% accuracy, do you want it now? This is the first question. And actually, this blood test has been published in Nature Medicine just a few months ago. So do you want it or do you not want it, or are you thinking about it? So there's a lot of questions and queries. It really depends on your own perspective. So the second thing that I'd just like to show is everybody knows Alzheimer's disease is an extremely complex disease with a long asymptomatic preclinical phase. So you might have a long phase of asymptomatic disease. That means you might have degeneration. We might all have degenerations of Alzheimer's in features in our brain, but we are still function relatively cognitively normal for about 10, 20 years or even more before people would get aged and deteriorate. But the problem is, the good thing is that we have a lot of biomarkers. The most advanced biomarker suggested by PET scan is the amyloid PET scan, which may show markers of neurodegeneration 20 years before the onset of cognitive impairment. So this makes it very complex. The other thing is coming back to the question of Alzheimer's disease testing. Why do we want to test? Then from the clinical perspective, there must be a reason that we want to test. Otherwise, there's no meaning for the testing. These are the three main goals that we probably would think if we want to test, or we want to offer a test in the clinical scenarios. First is maybe early disease identification. We want to identify the disease as early as possible. The second perspective is, of course, we want to have early disease treatment, or at least something that can be done to attenuate, if not cure, the disease or the impairment. The third, about the complex neurological disorders like Alzheimer's disease, which would lead to global change in cognition, would be, could this testing help us to have better healthcare planning way in advance before it comes? So how about early disease identification? So this is not a whole list, but generally we have different disease testings for AD, genetic testings for the very rare type of autosomal dominant inheritance. Technically, there's no problem. It's very easy. We talk about a lot of very sophisticated imaging, this genetic testing this morning, which is this autosomal dominant inheritance testing for these genes is extremely technically feasible, very simple. But it only accounts for 2% of all the Alzheimer's disease. The second is the susceptibility gene for the common form of late-onset Alzheimer's disease. We have a lot of studies, many studies, about a few hundred genes have been implicated, but up to now we only have one, which is the apolipoprotein E gene, which is the well-replicated susceptibility gene for Alzheimer's disease, the common form. So that's genetic testings. How about biomarkers of neurodegeneration? It's a whole range of biomarkers of neurodegeneration, ranging from cognitive function, which actually predicts about 80% of Alzheimer's deterioration in 2 to 3 years, to the very sophisticated PET scan amyloid deposition, which would show up that you have amyloid plaques 20 years before you have clinical deterioration. Or we have biomarkers just published in Nature Medicine, a panel of proteins which predict disease onset in 2 to 3 years with 90% specificity. So the range of biomarker changes are that we have a lot of these biomarker tests which have different characteristics, but none would give you 100% prediction and 100% sensitivity and specificity. So how about genetic testing? The predictive test for the very early onset cases is there, but it does not concern most of us because it only predicts 2% of all the Alzheimer's disease that we are seeing. For the susceptibility gene, the ApoE4 gene is common late onset gene. The positives, the questions to ask is if there is a positive test for ApoE4 genes, which would increase 3 to 10 folds with an earlier onset of illness. Earlier onset of illness may be genetically a normal person. An average person may have Alzheimer's at the age of 80. But if you have this copy of ApoE4 gene, you may have 5 years earlier onset, like 75, you have onset of significant impairment. And if you have 2 copies, both chromosomes have ApoE, you may have an advanced 10 years or 70 years of onset. But if now you are 30 years old only, so would you want to know that you might have Alzheimer's 40 years later? Because you might die much earlier, before the onset of disease. So this is not definite for clinical disease in your own lifetime. Even if you live long, there are other factors which might have delayed the onset of clinical disease. So the question here is, we know that if we have this susceptibility gene positive response, positive answer, but it is an increased susceptibility, but not determining that you must have Alzheimer's disease in your own lifetime. How about biomarker evaluation? The whole panel of different types of biomarkers, all have different values. They are markers of neurodegeneration, so they are more predictive in the sense that these biomarkers may give you some hints that our brain is not working very well or may not be working very well in the future years. The most sensitive test at present is the amyloid test, amyloid PET scan. We will have tau PET scan coming up in the near future, and that shows neurodegeneration up to or even more than 20 years before symptom occurs. So in the mid-age, some of us have already, if we go for amyloid PET scan here, for everybody, we might have 10 or 20% already showing up amyloid burden in our brain. These tests have high predictive value, but then the time frame could be very, very long, depending on your own personal characteristics. But how about the other markers? Some markers have high predictive value, like the protein panel that has just been published in Nature Medicine. is supposed to have high predictive values, predicting disease onset in the next few years, in the near future. But if you ask the question, that the paper did not talk about the cognitive function of this group of subjects who might have already been impaired, because nearer to the disease onset, what we call disease onset is actually a gradual thing. And the person might have already had subtle impairment. So do you need to know, do you need to have additional biomarkers? This is another question. Some of other tests, some may be invasive, like if the cerebrospinal fluid tapping is very safe, but it's still invasive, probably not welcome in this locality. Very few people in this locality would opt for CSF testing to predict Alzheimer's disease. Some are expensive and some may be radioactive. These are relative costs. If we think about the whole community, who are aging community, then this could be cross implication. The worst is some people, if even have worse or the good thing, or depending how you flip the coin. Some people who have positive biomarkers, you might have a positive amyloid burden in your brain, but then you are still normal in cognition. So these are not 100% specific and also not 100% sensitive. So these are some of the questions that is very difficult to answer. So biomarker and also genetics testings help to identify early disease with satisfactory psychometrics, but does it help you to give your individual answer to would you like a test now? So why do we want early identification? This would be the second goal for testing. The reason that we want to identify the disease early is, of course, we want to have early disease treatment. But the answer to this, as said today, is curative treatment for Alzheimer's disease is not yet available. Major pharmaceutical companies are now pulling off from the market of research for curative treatment. Available treatments are only symptomatic. We have only a few drugs that offer no disease-modifying effect with only some effects on symptomatic improvement. On the other hand, there are many research to suggest that protective factors like lifestyle, activities, physical exercise, cardiovascular fitness, good vascular health, and absence of depressions, these are all strong protective factors against the development of Alzheimer's disease. So would positive testing from biomarker or genetic testing would really influence the lifestyle or the risk factor modification? If you go for an amyloid scan and you find that you are positive, would you do more exercise in the next 20 years? Would you care for your hypertension much better? If so, there may be a role. But the second question is, do we really need a positive test results to change to a healthier lifestyle? These are just healthier lifestyle that everybody should think about. So you do not need to have an ApoE4 positive response to go to the gym or to walk. And you do not need your hippocampus to be atrophic before you think about you should lead a more healthy cognitive lifestyle to be happier. So these are, at current stage, we do not have curative treatment. We know about the epidemiological protective factors, but these factors should be applied for everybody. So this is another thing that we will be concerned about. We do not have curative treatment at now. But the following question is, curative treatment may be available. We don't know when, but may be available in the near future or in the next few decades. Earlier knowledge about oneself or about patients would give special attention to new treatment options. But this, at least for the time being, is only available to societies and community with resources, and also to the community who are selected with high education. So in the foreseeable future, even with optimistic hope, curative treatment, knowledge about early disease would only affect a few who are well informed. How about the third goal of genetic testing or other Alzheimer's disease testing is to have better healthcare planning. Better healthcare planning could be related to how you think about yourself, how you plan about your future in terms of financial arrangement, in terms of arrangement for enduring power of attorney, and other medical legal issues, or even advanced directives, or other medical insurance. A lot of family planning would probably be affected if you're very well informed, if you know about it. But these are very complex issues that needs to be individualized in every different situations. One of the examples that I have encountered is a good friend who actually knows very, very well about Alzheimer's disease. He goes for ApoE4 genetic testing because he is thinking about having a new life with a new planning, a second life, so that takes him 20 years. So he needs to go for testing and see if he's able to or should have a reasonable chance that he could compete or enjoy his second part of his life. So he go for testing. So this is a very peculiar situation, but for most of us and most of the people, would this testing help us to have better healthcare planning? That needs a lot of community education, health literacy issues that we have to think about and discuss. So how about the other side of the story? Is testing always good? Knowledge about testing always good? We have to think, because psychological reactions towards positive testings, maybe the literature about Huntington's chorea is so well known. Knowledge about Huntington's chorea would lead to depression and anxiety. The same thing happens for Alzheimer's disease. If you know that you might have a higher chance of Alzheimer's disease, you may be depressed or anxious. You're more sensitive to subjective cognitive problems. And we have to know that chronic stress is actually a risk factor for Alzheimer's disease. If you get tested at the age of 40 knowing that you are quite positive for the risk of Alzheimer's, you get depressed for the next 20 years, then this is an added stress that would harm your brain and cause your hippocampus to become more atrophic. So this is biological, physiological things that we need to think about. The other is another article published in American Journal of Psychiatry last year is people who knows that they are genetically predisposed to Alzheimer's disease actually has poorer objective cognitive result. This may be related to self-efficacy issues. Interestingly, that this study says for those who know that they are genetically negative, they think that they perform better in terms of memory tests, and they did perform better. Those who are informed that they are ApoE4 positive, they're genetically predisposed, they think that they're worse, but they did perform worse. So is this self-efficacy actually would influence functional impairment in the long term? The other thing is about stigmatization and logistic issues. These are things that we all need to think about. So how about considerations? These are individual considerations when we think about genetic Alzheimer's disease testing, not only genetics, but also biomarker testing, like family history, age. If you are young versus you're old, it's very different. The current cognitive function, if we are perfectly normal, you may not bother what you want to know. If you are not very normal, you started to think about. If you have already been impaired, you are not concerned about it. So this current cognitive status would have considerations. And other specific concerns and the test specificities. So I would like to end this by throwing some considerations with, I feel might be slightly more specific for the Hong Kong Chinese community. Strong family history, some families do have strong family history. The current cognitive status, early detection is not widely known in Hong Kong. It is coming up, people think about cognitive problems in the wider perspective, but still early detection, massive screening, at a reasonably good standard is still a taxing task here. How about specific concerns? We do not have disease-modifying agent as at present. And financial planning, we have very limited community awareness, health literacy in the community to know about the implication of financial advanced care planning. How about predictive tests? The ApoE4 prevalence in this community is extremely low. It's less than 10%. So ApoE4 as a community screening for late onset Alzheimer's disease is not a very feasible option in this community. We have other risk factors that account for the high prevalence of Alzheimer's disease. High cost is definitely prohibitive. Not many people could afford to have a PET amyloid scan to be conducted only in one private hospital in this locality. Invasiveness as cerebrospinal fluid investigation is basically not acceptable for most older people in this community, at least at present. How about the potential harm of subjecting yourself to have repeated PET scans? of radioactivity. So this is the upcoming issue, but at present it's a relative issue, but it's not absolute consideration. So I started with a lot of questions and end up with even more confusion. Thank you very much.
Thank you very much, Professor Lam. I think just now the two panelists have addressed the topic in a very complimentary way. Dr. Maskey has started off with some general discussion about the ethics of genetic testing, and then Professor Lam has then anchored the discussion using Alzheimer's disease as a specific example to talk about the various issues of ethics involved in genetic testing. So I'm sure you are now very ready to share your views too. So I'm now opening the time. Yes.
Those were great and very complimentary presentations. Thank you. For Professor Lam, your last points were that the prevalence of ApoE4 is lower in Hong Kong or in Chinese populations than in the West, and that there were other factors that account for the high prevalence of Alzheimer's in China. I'm wondering if you could elaborate on those. How much lower is the genetic prevalence? Are there other genes and what the other factors are?
For ApoE4, I think the prevalence is roughly just half of that in the Caucasians. In the normal population, the prevalence of ApoE4 is about 14%, something like that. From the Southern Chinese data that we have got is about 6 to 8% for the normal population, so it's much lower. Even for the disease group, for those with Alzheimer's disease, the odds ratio are very similar. But I think in the disease population, those with Alzheimer's in the Caucasian population is about 20-something%, roughly 1/4. But in Hong Kong, it's about 1/6. 1/5 to less than one, it's about 15% or slightly lower. So the risk factors just by ApoE4 would be much lower. So that has some implication on genetic testing for late onset Alzheimer's disease. But we have other risk factors because this particular group would have risk for vascular problems, hypertension, diabetes is much high, high prevalence compared to the Caucasian. And also the peculiar things about this group is the education level is much lower than the Caucasian population. We know that education level is a risk factor. And first is education. The second is their lifestyle, very simple type of lifestyle, not much complexity, less intellectual activities throughout the life course, another risk factor. And the job nature is the Chinese people usually would adhere, the older cohort adhere to only one type of job for most of their lives. So this kind of cognitive research thing put them more at risk. So it's a combination of different things that would offset the beneficial effect of a lower ApoE, but still have a high prevalence of Alzheimer's disease.
I don't know the data on ApoE4 for the non-Caucasian population in the US, and you may know that, but I know that the same risk factors that she just described for Asians is similar in the United States for African Americans. African Americans are at greater risk of getting Alzheimer's in the US. It's buried on the Alzheimer's Association website. If you go on the website, you have to really look, but it's not non-African Americans, it's African Americans. And the theory is some of the same issues about vascular disease and hypertension and lifestyle.
Yes, Mrs. Go.
There's always been this theory that Alzheimer's in Hong Kong, the patients are generally of low education. Has anyone gone into the research the fact that 80 and 90-year-old persons in Hong Kong grew up during the war? They had very little opportunity to have education, but they could still be highly intelligent. And so, where does this theory come from that low education is one of the causes of Alzheimer's?
So, yes, there is a theory about cognitive research thing and then neuroplasticity. So education is not only referring to the school education. School education has added benefit of social interaction, but education is talking about the lifelong learning approach. And this would help to build up our reserve in terms of compensatory strategies as a whole group. For the neuroplastic thing, they think about in more synaptic, the brain cells have more networking, from the early stages onward. If you have a continuous cognitive stimulation throughout your life, and then you have a better compensatory strategy. It does not affect the pathology of Alzheimer's disease. It only affects how much we could compensate. That means you save more money in your bank when the economic downturn comes. You can survive for longer before you get bankrupt. So your disease burden would be similar. So about the very old people in this locality, we also investigate some of them, the risk factors for them to develop Alzheimer's disease is actually if they have additional stroke, just like the lung study. If very old people, 85 or above, if they have additional stroke, if they have additional risk factors, and that would tip the balance and they're more likely to become demented. But as for those who are very active, they may have low formal education, but they're very active. Their cardiovascular health is good. They do not have family history. They still could survive very well into the 90s.
Yes, Dr. Lok?
Thanks. It's a very enlightening and exciting topic to discuss about Alzheimer's disease ethics. At the same token, do you think we should diagnose and label people with mild cognitive impairment actually? Because you create a lot of anxiety among even normal people. You label them as mild cognitive impairment, MCI, because at this moment, we do not have drugs that prevent whether MCI can go to Alzheimer or not. So it's worth discussing issues too about MCI in the ethics.
If I understood your question correctly, so were you asking, should we test for MCI or should we be talking about it and how to deal with it? What was it, testing? Is that?
Actually, labeling and diagnosing.
Oh, labeling and diagnosing, yeah. I have concerns about pushing diagnostic categories to preclinical status. I'm not an expert in the science, and I know the science is overwhelming in some cases for certain kinds of categories of disease. But I do have concerns about pushing a category into a mild cognitive impairment preclinical category, and what that means then for all the other kinds of issues that result in terms of how one manages one's life and how one manages the health trajectory. I'm not convinced that there's good evidence yet. I'm sort of convinced by some of the critics of the theses of Alzheimer's, being a non-expert. So I'm a little reluctant, and I think it does have implications for how it has cost implications, absolutely, for testing and how we manage. And it has implications for people's identity of themselves, and it will clearly have implications for families. So I don't know if I answered in a way that you were thinking, but.
Yes, Professor Wu?
I'd like to give a slightly different perspective regarding ethical problems in screening for Alzheimer's disease. And that is that I think from what we've heard, there's a lot of research being done about what are possible methods for screening. But to my mind, they're still at the research phase. For example, if you say that you detect amyloid plaque, there's a different school of opinion to say that amyloid plaques have nothing to do with the disease, because if you get rid of them, they still have the clinical syndrome. So should you be detecting amyloid plaque? Should you be detecting something else? So fine, there's a lot of active research going on, but when you translate it into what to do in a clinical setting, in the public screening and so on, are we any further forward than many years ago when you take a history from somebody, there's a thing called family history. I mean, how are you adding any more accuracy to that if you have a family history of whatever, you're more likely to get it? Can we actually improve on that? So I think that we're still at the research phase, and the ethical implication is that if you suddenly use this material and translate it to what you can actually do in a healthcare setting, people are going to make bad use of it. The commercial company is going to push it. The private clinics are going to recommend this amyloid scan, very expensive. And what does it do? We have really no evidence that it's altering management. And so I think that from a health system point of view, you still got to stick with the fact that it's a common condition, you can do something about it, and all those principles. I mentioned this in the previous section. There's still a big gap, and many things we don't know. And the other thing is we keep talking about Alzheimer's disease. If you think of dementia as a geriatric syndrome, which is how I think we should think about it, because it's very common, what percentage of the dementia syndrome is actually Alzheimer's disease? Is it always so pure? It's never so pure. It's always a mixture of, a lot of cardiovascular disease, cerebral vascular disease, post-stroke dementia, microvascular disease. It's a mixture in real life. And there are studies showing that if you have lots of amyloid plaques, you can be clinically normal. And after all, the disease is a diagnosis at death. It's a post-mortem diagnosis. So should we be focusing more on brain reserve, that in midlife, you do what you're told to do, have a healthy lifestyle, and actually that would be very effective in reducing your risk of late life dementia. And the impact of that is surely much more, much greater than we're focusing on screening for Alzheimer's disease.
Thank you, Professor Wu. Professor Lam or Dr. Muskie, you want any response?
I think to follow up with Professor Wu's points is the predictive value of pure but comprehensive cognitive testing in a few years, if the disease would onset in the next few years, could be up to 80%. So even for very clinical but comprehensive cognitive testing, purely non-invasive, the predictive value is already quite high. So that means if you have some cognitive impairment, that would give you a strong hint, some specific sets of cognitive impairment that would give you a strong hint the disease is going to go downhill. You probably, even for the very sophisticated tests like the nature medicine test, the predictive sensitivity and specificity is 90%. So it is just an added statistical change of 10%. So do you really need very invasive testing or even non-invasive but sophisticated testing without a clinical marker? So that's a gap. Research is different from the clinical application, I would say. But to follow up with Dr. Luke's points about labeling of mild cognitive impairment, is the same questions arise many years ago. Every time when we talk about early identification, some people would ask, do we need the knowledge about mild cognitive impairment? I guess if everybody is very health conscious, knows about the disease well, and knows about the importance of lifestyle modification, then probably it's the common knowledge. We may not need specific instructions. But for the degree of health literacy in this community, older community, some knowledge that they are started to have some kind of cognitive impairment may occasionally, in some specific cases, would lead to very dramatic change in lifestyle. I have a few cases, not many, who started off over 10 years ago with cognitive testing research. They know that they are impaired, and then every year you come back and test them, they only improve. And you ask them why, what have they done, and they said, after you told me that I have some impairment in memory in the testing, I do a lot of things, changed my diet, got diagnosed to have hypertension, found that I have diabetes, I do exercise every day. So that changed a lot. So this knowledge about how to live healthier and better should be a public health perspective. So if everybody knows about it, then we did not need screening.
Professor Yi?
I guess what we will be discussing over here is that whether we want to know even that the predictive testing or the genome sequencing. I'm wondering whether there any the study has been. I guess here that we're saying that do we need it? Well, it's a study. I mean, there are some kind of consensus that we don't need it. But however, probably if you're really going back to the community or people, maybe the people in the community, maybe they want it. So let's say that if there's any company trying to marketing this Alzheimer testing, go to that some of the towns saying that you are 80. If you know that you are going to Alzheimer or not, even like at 80% or 90%, even 70%, you could prepare better for your future in terms of living, etc., the family arrangement. So then they're going to buy the test. So I'm wondering, is there any test, any kind of study, really looking at what other kind of consumers' view or what other kind of the willingness to accept that testing from the elderly people?
I haven't seen any. It may be out there. Your argument is, I think, a really good one. The question I would ask then is, should the government pay for it? So that's where we get to cost effectiveness of diagnostic testing and priority setting in healthcare services and healthcare resources. People can pretty much get whatever they want if they pay for it on their own. But should a national health system or the crazy fragmented, unbelievable system in the United States pay for that test if the insurer believes that makes a strong case? I mean, we can disagree with that. But the evidence base for getting that test is, I agree with Dr. Wu, I'm on that side, that the evidence base does not give us anything more than we already have. Now, it may in 5 years, but right now it may not. So my next question would then be, who pays for it? And if we have limited resources in a national system, or our national system is the Medicare system, limited resources, then somebody has to make decisions about whether or not the value added to that test is worth the cost for all the reasons that some people may argue they want it.
Any further thoughts or questions from the floor? Yes.
I have a question which is similar to what Dr. Luke mentioned about the diagnosis of MCI. So similarly, I would argue, what's the purpose of diagnosing Alzheimer's disease? I mean, to a person, if I'm diagnosed with Alzheimer's disease, what good does it have for me? Of course, we know that there may be some good to it, but that could mean, it's a similar argument with being diagnosed with MCI. Perhaps it has no value to the person concerned, but of course, from Dr. Lam's, Professor Lam's example, it has some value, but it has a lot of value for the people around her or him. So, what is your thought? I had an argument with a medical colleague before. I diagnosed her patient with Alzheimer's, and she was furious with me. Why did you do that? So, she was she was a 80-year-old, and she was, you can call her happily demented, But I could see that the family does not know that this is coming along, and they have to be prepared for something like that. And so I talked to the family about this, and so my colleague was not happy with me. She believes that, you don't have to diagnose Alzheimer's disease in somebody like that. So what is your take on this?
Dr. Muskie?
Oh, well, I'm not advocating not diagnosing. I'm concerned about diagnostic tools for which people may believe there's evidence that it actually is resulting in a true diagnosis. That's my concern, that some of the tools are not necessarily on their own a diagnosis, and in conjunction with other tools they may be, but it does raise some important issues about when do we do the testing and how we do it, and is there consent for it? Maybe the patient doesn't want to know. Maybe the family does, but the patient doesn't. Then what?
And then whether your colleagues is having stigmatization and discrimination.
Thank you. So with this, I think I have to close the panel discussion for this session. So thank you very much for the two panelists and your contribution.